Good afternoon, everybody. A big thank you for having me to speak here today. I am Phil Thompson. I'm a full-time GP in Malvern in Worcestershire. And for the last 3 years, I've also been the clinical lead GP for children in South Worcestershire. And during that time, I've been working on a number of projects surrounding child health. And that's really because I'm personally very passionate about improving the care of young people, but also about supporting GPs and all those other people who look after children. So this is what I'd like to talk to you about today. And this is a piece of work that we at South Worcestershire CCG have done to try and support GPs and all those other people that provide urgent care services to children. And what we've done is we've developed some guidelines that cover some of the most common reasons why children might present to urgent care services. And it covers things like bronchiolitis, croup, and fever. What this document aims to do is to encourage the provision of outstanding evidence-based care, yet with a strong hint of real-world pragmatism. And this document was written by a team of professionals, not just myself, also a consultant paediatrician, a consultant nurse, and a consultant community paediatrician, as well as a number of other allied health professionals. So really what this is, it's something that was written by clinicians for clinicians with a specific understanding of what we have at our disposal locally. So you might ask why we came up with these guidelines. Well, the reason is because we, like much of the UK, are facing a challenge. And it's a really big challenge, actually. We as clinicians and commissioners are facing the challenge of providing outstanding care at a time of extreme financial pressure. And one of the biggest challenges we're currently facing is that of rising admissions. Now, this graph shows the pattern of paediatric admissions to our local hospital, the Worcestershire Royal, over the same 6-month period in 2014 in blue and 2015 in red. And as you might expect, there's some variation across the year. But what this shows is that between 2014 and 2015, the absolute number of admissions really started to increase quite significantly, as you can see as the lines diverge. And what we've actually realised is that this is a pattern that's being replicated not just across the West Midlands, but also across the whole of the UK. Now, the challenge of rising admissions brings with it another challenge, and that's also the fact that the cost of admissions is increasing. Now, I'm always really surprised at how much it costs to admit a child to hospital. So, for instance, the Worcestershire Royal, as soon as a child sets foot through the doors to be admitted, it's at least £208. And the average cost of admitting a child in Worcester is over £850. And this chart shows the spend increase in Worcestershire between 2014-15 and 2015-16. And this is the mean monthly cost of admissions during those years. So for every single month, on average, over that year, the costs rose by £30,000. And that's a lot of money. One of the things we've noticed is that actually we've probably got a bit of a problem with admissions of less than 24 hours. Now, these are very short stay admissions, and you can see that their numbers went up quite significantly between 2014-15 and 2015-16. Several hundred more children were admitted over that year for periods of less than a day. And actually, if we look at this, a lot of these children were admitted for significantly shorter periods than that. But you might ask, what's the particular significance of these very short stay admissions to us as clinicians and as commissioners? Well, there are two questions that come to my mind. The first one being, did all of those children really need to be there? And the second one, were there any interventions that could only have been done as an admission to the ward? Now, if the answer to those two questions is no, then we have an opportunity to think of a different way of managing these children. So what I thought we would do is look at some of the reasons why these children were being admitted to hospital for short periods of time. And this is some data from Worcestershire Royal. So the 3 most common reasons why children were admitted for periods of less than a day were for a viral infection, an acute upper respiratory tract infection, i.e. a cold, and acute bronchiolitis, which to any non-clinicians is a respiratory condition that affects very young children and babies. And again, all three of these reasons for admission increased quite significantly over that year. And we really have to ask ourselves, did all these children who essentially had viral infections really need to be admitted to hospital? And the fact that they stayed in hospital for less than 24 hours might suggest that they didn't. So we have to ask, how did they get there in the first place? So why have paediatric admissions been rising? Now, in the modern clinical climate of immunising our children and the way we manage long-term conditions, it seems pretty unlikely that children are simply getting sicker. There's no doubt that some children definitely need to be in hospital, but there are probably many children that don't need to be in hospital that get admitted there. And it's actually really important to remember that being in hospital when it's not necessary creates a problem. It creates stress for the children that are sat on a busy ward, it creates anxiety for their parents, and it also uses up limited resources and potentially diverts attention away from those children who really need inpatient care. And so what we've done is we've thought of some possible reasons why admissions to hospital might be increasing, because to really try and do something about it, we have to understand why it might be happening. So this is probably something that many of you may be familiar with, given press over recent weeks. And some of you may have seen headlines such as these. Now, as a GP, I've seen the workload crisis facing primary care firsthand. So, for instance, on a busy day for me, it's not uncommon for me to see 50 or more people on a face-to-face basis. And on average, I probably see at least 10 unwell children per day. Now, when we're assessing unwell children, we often have some quite difficult decisions to make. Because if we're a bit worried about a child, we've got the option to send them into hospital, and we know that there they'll be safe. Yet sometimes there's an alternative to doing that. We could intervene, we could do something to keep that child out of hospital. So, for instance, if you take a child who's having an acute exacerbation of asthma, we could send them into hospital quite easily. Or we could give them some steroids, give them a nebulizer, and arrange to review them in 10 minutes, an hour, 4 hours, or later the same day. And that second option will often work and will be all the child needs to get well again and stay out of hospital. What it does do, though, is it increases our already busy workload even further. And the way that GP surgeries are structured means there's often not the capacity built in to review children the same day. Put quite simply, it's often quicker and easier to send a child into hospital. Another thing as clinicians we all worry about is missing something really serious. So I'm sure many of you at some point may have seen news articles like this. Now, children in particular can be really difficult to assess when they get ill, and that's because they have this physiological ability to compensate for being ill for quite a long time. What that actually means is that they can appear to get really sick really quickly. And sadly, we've probably all heard a story similar to this about a child who saw their GP or who went to A&E and were told that they had a virus and subsequently turned out to have meningitis. So we as doctors and nurses are increasingly aware that we simply must not miss serious diagnoses. The consequences of doing so are so serious not only for the patient and for the family, but also for us as clinicians, with increasing fears over medical legal action and even things like gross negligence manslaughter these days. There are a few other possible reasons why we might be sending more children into hospital. So there's no doubt that there's probably an increase in expectations from parents, with people wanting an expert opinion really early on in the course of an illness. And furthermore, there may be a problem with our experience as GPs and our confidence in managing and diagnosing children. For instance, a formal paediatrics job is not a compulsory part of GP training, so it's quite feasible that a GP could complete their training having done no more than a few weeks at medical school formally training in paediatrics. And certainly evidence suggests from our local hospital that those GPs who haven't done a formal paediatrics job tend to admit more children to hospital and also refer more children to outpatients. So, These are some reasons why admissions might be going up. And this is why we decided to develop some guidelines on paediatrics. We recognised this trend of rising admissions and we wanted to do something about it. So we looked at a sample of those admissions to our local hospital by doing a prospective audit. And we found that many of the children who'd been admitted could potentially have been managed without being admitted to the ward. And furthermore, we found it was the same handful of conditions, resulting in a number of admissions that were potentially avoidable. We thought that we might be able to reduce admissions and at the same time improve care, if only we could improve understanding. We wanted to improve understanding about paediatric illness and why children present to urgent care services. We wanted to provide guidance on how best to manage unwell children, and really importantly, to guide clinicians on which children should be admitted to hospital and which could potentially be managed in the community. And we also wanted to provide support to GPs, to A&E, to out of hours, and to all those other people that look after children. And one of the ways we wanted to do that was by building relationships between primary and secondary care and encouraging people to ask for advice if they weren't sure what to do. So this is what we did. We came up with the top 10. And what this is it offers guidance on managing what we felt were the top 10 most common reasons why children present to urgent care services in Worcestershire. So what I don't intend to do is go through this all with you because it's a long document and you're more than welcome to look at it and use it as you wish. But what I thought I'd do is just talk you briefly through a couple of the guidelines, how they work and what they encompass. So if you cast your mind back to some of those common reasons why children were admitted to hospital who potentially didn't need to be there, bronchiolitis was one of them. So we developed a bronchiolitis guideline. Now this is the guideline in full, and it's a fairly busy slide, so I don't expect you to read through all that. But those of you familiar with NICE guidance will recognise that this is very much in line with the NICE guidance surrounding bronchiolitis. NICE use a traffic light system of assessing a child, with green symptoms and signs being reassuring, amber symptoms and signs being a bit worrying, and red symptoms and signs being very worrying. So if, for instance, we look at some of the green symptoms and signs, or the ones that should reassure us, this is really about how we as clinicians are assessing a child. So we're looking at the child and they look bright and alert, their skin's normal, they're breathing at a normal rate, their oxygen levels are normal, they're feeding well, and all these things are very reassuring. What that means then is if we follow this guidance and we've identified that all the features are green, we can be reassured that this child can be managed at home with appropriate care and advice. In order to provide that, with every guidance we've written, we've come up with a parent information leaflet regarding the condition to give them more advice. And what this is really careful safety netting for parents. It's all very well as reassuring and assessing a child and saying they're fine, but then we really need to give parents the information that they need to make a decision about when they might next need to seek help. So again, the information leaflets use the same format of green, amber and red, and their parents are guided as to which service might be the appropriate one to seek review if they're concerned. And really, this is a way of us encouraging patient self-care. Obviously, if when we're assessing the child we deem that they've got amber or red symptoms or signs, then the guideline would guide us through to take the appropriate action, often including an admission to hospital. So as well as coming up with guidelines regarding acute respiratory conditions, this again is a somewhat busy slide with a very unsnappy title, but this is a guideline that we came up with totally from scratch. And this is really trying to address those babies who are crying and unsettled and we don't quite know why, but we think it's probably something to do with the way they're feeding. So the title is The Management of the Unsettled Infant, where the cause is thought to be related to feeding. If anyone can think of a better title, please let me know. And what this really encompasses is the 4 very common causes of an unsettled child during or after feeding. So it covers things like gastroesophageal reflux, infantile colic, cow's milk protein allergy, and lactose intolerance. And whilst the slide itself is busy, the algorithm is very easy to follow, and it guides a clinician through picking out symptoms and signs that might help them to determine what's going on. One of the things we've particularly tried to do is to reinforce to people what is not abnormal. We're quite good as doctors and nurses to pick out things that are definitely abnormal, but actually realising what's a variant of normal can sometimes pass us by. So really just highlighting the things that should be considered not abnormal is very important. And what this guideline does is it guides us through the likely symptoms towards the most likely diagnosis. And then for each of the most likely diagnoses, there's a further flow chart which gives further reassurance about the likely condition and then step-by-step guidance on how to consider managing it. Along with pointing out what's not abnormal, it's always really important to point out what definitely is abnormal. And in medicine, we call those red flags. So all of our guidance will feature some advice about which red flag symptoms we need to watch out for. And red flags are those symptoms and signs that prompt us as clinicians that something is seriously wrong and we need to do something about it. When we were developing the guidelines, we worked closely with a team of people, including pharmacists. So we'd like to think that all of the treatment we've recommended is not only in line with best practice evidence, but also cost effective. One area which GPs, I think, struggle particularly with is milk problems and knowing which milk to try if they think a child might have a cow's milk protein allergy or a lactose intolerance. So along with our pharmacists, we came up with some advice as to which milks might be prescribed for certain conditions, such as cow's milk protein allergy. So we've given, for instance, a couple of brands. We've given advice as to whether these milks should be prescribed or whether they could be purchased. And we also give advice on when you might try challenging that again and introducing a non-prescription milk. One of the most important pieces, I think, in our guidance is this box. And this is an option on many of the pieces of guidance that we've written. When we were developing our guidelines, we worked very closely with the consultant paediatricians at our local hospital. And they felt that they would be happy to assist any doctor, nurse, or anyone dealing with acutely unwell children in making the right decision about how best to care for them. And so as an option in many of our guidelines, you'll see this box. And what this means is that we're empowering GPs, nurses, A&E staff to pick up the phone and ring and speak for advice if they need it. Because if we can give people the right advice at the right time, we can look after children better and hopefully keep them out of hospital if they don't need to be there. So all of the consultant paediatricians at the hospital have signed up to say that they are happy to speak to pretty much anyone at any time if they've got a concern and would like advice. So that's a bit about the guidelines that we've developed. And in terms of how we've used them, well, what we did was, because it was quite a big project encompassing our local health and care trust, several CCGs, and an acute hospital trust, they had to be agreed by all those different boards. And so the guidelines were issued simultaneously across all those platforms on different websites. And we communicated with people directly to let them know that they were there. So they went out in our CCG bulletin, which is read quite carefully by local GPs, so I believe. We also communicated directly with the clinical director of the out-of-hours service and with the A&E director. And we send out regular reminders about using them. And the consultants at the end of the phone are also primed to encourage people who are ringing up to make sure that they've used the guidance if it appears that they haven't done. One of the schemes we have in Worcestershire as well is something called IQSP, which is a quality improvement scheme. It stands for Improving Quality and Supporting Practice. And it's a way of us trying to encourage practice to use best practice guidance where it's available. And so the CCG made it a mandatory requirement to have these guidelines accessible on every clinician's desktop so that they can be accessed quickly. And South Worcestershire are actually leading the way in our use of clinical pharmacists in a pilot that's going on, and they're really pushing the use of these guidelines with patients that they see and with colleagues that they encounter. alongside developing our guidance, there's a number of other things that are changing in Worcestershire at the moment. So we recognise that getting advice from a specialist may be the thing that makes the difference between admitting a child to hospital or not, and caring for a child in the best way and not. And so now consultants will take all the referrals from GPs and from A&E themselves. So when I was a junior doctor working in paediatrics, I held the bleep, and if a GP rang, I would take the referral. And with the greatest of respect to my junior self, I was really a secretary taking phone calls. But now, the consultant who takes the call can offer advice to the referring clinician over the phone, and actually they can discuss whether they think an admission to hospital is the appropriate thing to do. And alongside that, we've developed these things called hot clinic slots, which means that if a GP or A&E ring up wanting to admit a child, the consultant who's taking the call can triage them into an urgent clinic slot, which is often the same day or the day after, but that child can then be seen in the outpatients department by the consultant. And this is for the less unwell children who need seeing urgently, but don't necessarily need to sit on a bed in the ward. And that's really better for everybody, because it's better for the parents who don't have to sit on a busy ward, and it's better for the children who can attend in a timed slot. And it has an added benefit from a cost point of view, in that that's charged as an outpatient attendance cost rather than as an admission. So we recognise that developing some guidelines on how to manage some paediatric problems is not going to solve the problem of too many children being admitted to hospital that don't necessarily need to be there. And admissions certainly continue to be a challenge. But in South Worcestershire, we're really keen to try and continue to support GPs and the A&E teams surrounding the best practice management of children. And really what we're trying to achieve is to try and keep those children who don't really need to be there out of hospital. And instead, trying to provide the best possible care to children in the community. Thank you very much.